Welcome. Thank you for joining us. My name is Michaeline Friedenberg, and I'm the President and CEO of Life Perspectives, coming to you today from our national headquarters in San Diego, California. For those of you who are new to Life Perspectives, let me briefly start by sharing our mission and the goal of this webinar series. Life Perspectives is the global expert in reproductive grief care, offering evidence-based grief care education and training for healthcare professionals and community leaders. We are at the forefront of creating and distributing impartial and impactful research to understand the way individuals process reproductive losses so that we can establish global standards for offering reproductive compassionate grief care. Our quarterly Research Reveals lecture series features in-depth discussions with the authors of some of the latest groundbreaking reproductive loss research. I know this is a sensitive topic, especially since so many of us are personally impacted by reproductive loss. I just want you to know that we're mindful of that and that we're here for you. If you find yourself experiencing troubling emotions, or maybe you're thinking about someone who you would like to support, please consider the following resources: miscarriagehurts.com and abortionchangesyou.com. These are anonymous, interactive healing websites for men, women, family members, and friends impacted by miscarriage and abortion. We also have free e-toolkits that give you some tips on how to support others, which are available on lifeperspectives.com. There's also sympathy cards, remembrance gifts, including our signature Forget-Me-Not collection and our new comfort care boxes that are available in the shop on lifeperspectives.com. I encourage you to take a look at all of those great resources, but of course, please do so after the event. For now, I would like to introduce to you the lead author of the CME review article, Perinatal Loss, the Impact on Maternal Mental Health. Dr. Tenny Davoudian is a board-certified clinical health psychologist. She's an assistant professor of psychiatry and director of psychological services at Oregon Health and Science University's Fertility Clinic. Dr. Davoudian specializes in reproductive mental health and psychological assessment of potential donors and gestational surrogates. Welcome, Dr. Davoudian. Thank you so much for joining us.
Thank you so much for having me.
Oh my gosh, yes. Oh, but a quick note to our participants. Before we jump in, please feel free to submit questions throughout the presentation, and we will answer as many as we can in the final 10 minutes. But without further ado, let's jump right in. So again, Dr. Davoudian, thank you so much for the work that you do and for writing this paper and then for taking time to be with us. And I guess I'd like to just kind of hear from you, like why you think that this topic is so important.
Sure. I believe that researching and discussing perinatal loss is vital because, as many people who are tuning in know, miscarriage is not uncommon. So it's safe to say that at some point in our lives, most of us will know someone, a loved one, or be personally impacted by reproductive loss. So it's something that I think we might all be vulnerable to. I think why I like to talk about it as much as possible is, despite how common reproductive loss is, it's greatly misunderstood by the American public. There have been studies that have looked at just lay people and ask them about how often do you think miscarriage happens? What do you think causes it? And most people believe that miscarriage is very rare, like happening to like maybe 5% of pregnancies, when really the rate it could be up to 35% of pregnancies. And people also believe that factors such as having an STI, a treatable STI when you were a teenager, not wanting the baby, or other things that are not necessarily correlated with miscarriage to be causing the miscarriage. And as you can imagine, as a psychologist working with patients, I hear a lot of patients who've had miscarriage talking about the shame, the blame, the isolation they feel. And I believe that some of that is tied to kind of the gaps in knowledge that we have in society. So I'm always happy to be in situations like this where we can talk about women's mental health. So thank you for having me.
Oh my gosh. Well, thank you. And I'm just, as you're talking about this, I'm just thinking like just just the compassion that's exuding from you, and how wonderful that you would be devoting yourself, as you said, to this great need, but one that's often overlooked or our culture is silent. And so let's jump into some aspects of the review, so you can help us walk us through this and help us to better understand. So what are some of the psychological features that you found with perinatal grief?
Sure, yeah. And before I go further, I do want to mention that I use words like women or mother, and I want to say that, of course, not everyone who has a child or wants to have a child identifies as a woman or a mother. I just use those words to accurately portray the population that was utilized in studies. But I do want to say that, yeah, there's a wide spectrum of individuals who want to be a parent or are a parent. And I'm sorry, Dr. Fernberg, you were asking me about grief, correct?
Yes, yes. What are some of the psychological features of perinatal grief?
Yeah. Now, I want to start off by saying that not everybody who loses a pregnancy experiences grief. It's important for us as providers to not assume how someone is feeling afterwards. It's possible that the pregnancy was undesired, or perhaps conception occurred in a violent manner. But for most people, losing a pregnancy is emotionally challenging, and it is usually accompanied by pretty significant grief. And now grief is an expected normal response to any type of loss we have in our lives, whether it's tangible or intangible loss. So grief definitely has its place in reproductive loss. And what we have found through research is that the intensity of grief following pregnancy loss is as strong as one would have after losing a loved one. So it can be very significant and really impact one's life. A lot of reproductive grief looks like other types of grief, right? People feel overwhelmed. They feel isolated sometimes. They feel tired. It impacts the full body. But I think what's important about grief tied to reproductive loss is that it has some unique features. So, typically when we lose a loved one, we can get together with other people, talk about that loved one with them. There's ceremonies that we can do that are like culturally, recognized to honor the dead. But when you lose a baby, whether that's through miscarriage, stillbirth, or like neonatal death, so early after the baby's born, parents are kind of left with this heavy grief and not a lot of cultural acknowledgement, rituals, or expectations about what to do with that grief. So they're often feeling like they're alone in it. Something else that's different about perinatal grief versus regular old grief is that with the regular old grief, it's called retrospective grief, right? We're looking back on the person's life, we're thinking about the past. But with perinatal loss grief, it's called prospective grief. And that's because unfortunately, this parent or parents didn't have an opportunity to develop memories with their child. So instead, they're usually mourning what could have happened rather than what they had. And grieving in and of itself is a bit difficult. I think US culture kind of has this view that it's a problem to be fixed. And when you add this layer of like ambiguity on top for losing a child, losing a baby or a fetus, it makes the grieving process sometimes even harder for parents. So support is really important during that time for most patients.
Great. Yes, thank you. And thank you for pointing out that like each person's experience is unique. I think that's always really, really important to do, because sometimes, right, we can start to almost judge ourselves and put some shoulds on, or as you said, as caregivers, maybe make assumptions that aren't accurate. And I think too, pointing out, I think in our culture, maybe part of it is when you talk about the prospective grief, I think for many people, it's really surprising to think that it could be, as you said, as intense or maybe even more intense than what would be, as you said, a normal old grief that we go through. And I'm wondering, when you take that a bit further, I think we're always interested in, okay, that's the individual's experience, but how, what are some of the features? What does this look like, a perinatal loss in the context of relationships?
Yeah. I want to mention that there have been some research studies on the impact of perinatal loss on relationships. However, they're all heteronormative, unfortunately, as of right now. And even within the heteronormative studies, men's reactions to loss are still understudied. So we have a lot of work to do there, but we still have some interesting good data. We know that longitudinal data suggests that heterosexual men and women experience similar grief intensity, right? So no one is immune here, unfortunately, but how the grief is displayed it can vary greatly between men and women. And I see this a lot in my clinical practice as well. In heterosexual couples, I'll work with the mother and she'll say, I'm having a hard time connecting with my partner about this loss. He is just going up about his life like it's okay. He went back to work 2 days later. And so sometimes it's my job to provide some information about discordant grief expressions between heterosexual men and women. And what we do know is that for men, one way of coping is to, quote, return to normal. That's a really common coping skill that they utilize. We also know that in heterosexual couples, the father often feels like their primary role is to support the mother. And so they often feel like they don't have space to prioritize their own grief. And so it's not that he doesn't care. Sometimes it's because he just hasn't had space to even talk about it. And I do find that clinically that does help some couples navigate this really difficult time. There have been some research about how relationships are impacted long-term after reproductive loss. And what we know is that couples who experience miscarriage have a higher risk of their relationship ending 2 to 3 years following the miscarriage, compared to couples who have not had any reproductive loss. And couples who have experienced stillbirth or intrauterine fetal demise have their relationship is at a higher risk of ending up to 9 years following the loss of their child. So pretty long-term profound impact for some couples. And I do want to mention that for some other couples, it strengthens them. They are able to come together. So the reactions and the impact on one's marriage relationship can vary greatly.
Right, right. Well, I'm wondering, as you're saying that, do you think some of the grief reactions that you talked about, and as you said, discordant within a couple, I mean, is that because our culture expects, these individuals to react in that manner?
Absolutely. It's a huge part of it, if not almost all of it, right?
Mhm.
Unfortunately, men have a limited amount of emotions that they're quote unquote allowed to feel. And crying and sadness and grief and vulnerability, unfortunately, are not in that list. And in order to grieve, oftentimes you have to access those emotions. And yeah, culturally, it's just difficult to do so. And the recommendation is when providers do see a couple who have had a loss is to not just offer mental health resources to the mom, but also to the dad, because what we've learned through research is they also want mental health resources, but sometimes have a hard time finding like the right person to see. So I think as providers, that's something easy that we can do to make sure that both members of the couple feel supported.
Right, absolutely. And I think giving them both permission, right, to have whatever reaction that they're having. When you talked about the elevated risk for kind of dissolution of that relationship, did you find in the studies that you were looking at? I mean, was there a particular, elevated risk for each of them, percentage wise, or what did you find?
Yeah, I don't recall the details of it. I know this was kind of the aggregate finding that they had. I believe the authors, were wondering if unresolved traumas or mental health issues stemming from or becoming exacerbated by the reproductive loss may be underlying some of those relationship issues that emerged.
Okay. Well, simply knowing that, right, I think already, as you said, maybe alerts to some things that we can do proactively to perhaps help them in case they encounter those difficulties. So I kind of want to go back to the differences that you were talking about before between perinatal grief, and this time, this is a question that we often get asked, and that is like, what's the difference between perinatal grief and diagnosable conditions like major depressive disorder or generalized anxiety disorder or PTSD?
Yeah, that's a great question. It's a bit of a tricky task, I would say, even among seasoned mental health providers, especially differentiating between major depression and grief, because those two conditions share a lot of the same features, right? Sadness, apathy, low energy, sleep disturbances, changes in appetite. Those are all symptoms of depression, but also features of grief. So there's lots of overlap there. I think what's also difficult is grief and major depression can co-occur. So for example, somebody could have major depression, go on to achieve pregnancy, have a loss, and then will grieve the loss while they still have ongoing symptoms of depression. So it's a bit tricky. I would say differentiating grief from anxiety and PTSD is usually much easier just because there's not so much overlap in symptoms. But as far as how to do it for depression, there are a few things that we as providers can look out for to help to differentiate. And before I go into that, I do want to mention also that grief, of course, is an expected normal response to loss. However, conditions like major depressive disorders can be very serious, life-threatening, and they definitely warrant psychiatric and psychological treatment. So they often don't just resolve with general support like grief might. So course of symptoms is one way to figure out whether somebody may be having some major depression or grief. When someone is grieving, their symptoms often occur in waves. And those waves are often triggered by thoughts or reminders of the deceased. And the severity of symptoms can really vary greatly, even just hour to hour. So there's a lot of variability. Versus somebody who has major depression, their persistent depressed mood is just more persistent. It doesn't lift as easily or as often. Also, people who are grieving usually can access some positive emotions. So maybe not the day of, the day after, but as they continue grieving, they can still access joy or other things. Versus somebody who has major depressive disorder, especially if it's moderate or severe, it's mostly pervasive unhappiness and difficulties accessing really any emotions outside of sadness and sometimes anger. Sometimes I ask my patients about their thoughts to try to figure out what's going on there. People who are grieving are often really focused on the deceased and talking about their relationship with them, versus people who are depressed. I see a lot of self-critical thoughts. So themes of worthlessness, like I'm a burden to other people, really concerning things. Let's see what else. So self-esteem is another way to check to see how, where somebody might be on the grief versus major depression spectrum. For most people, when they lose somebody, their self-esteem is largely intact. I mean, they might have some guilt, like, oh, I should have gone to the doctor 2 days ago. Things like that are normal with grief, but with major depression, there's quite a bit of self-aversion, self-loathing that you typically don't see with grief alone. Sometimes we have to wait and see too. We might assess a patient 1 week, assess them 2 weeks later, and see how their symptoms are shifting to be able to decipher what's going on. So it's hard to do it right away. It just takes some reassessing.
Okay. Well, that's all of that is so helpful to hear that. And also I think good, as you keep pointing out, that grief is a normal reaction, right? It's not pathological, but there may be these other features and aspects of it. And seems that potentially for a care provider who's not a mental health specialist, that would be a time I would imagine that they may want to then encourage some additional assessment to tease out what's happening so that they can get the proper support and potential treatment.
Yeah, absolutely.
Great. Well, I wondered in when you were looking at the literature and what we know about perinatal loss, did you already noted a risk factor, but I mean a risk that come of it. But did you notice any risk factors? And then I'm also wondering, did you notice if there were any protective factors?
Yeah, absolutely. There are several factors that have been identified as being a risk factor for increasing, occurrence or exacerbation of psychopathology following a loss. One of the most common and obvious ones is history of mental illness, especially if it's not well managed or not consistently well managed, it's likely that there would be a recurrence or exacerbation of symptoms following a loss or leading up to a loss. We also know that individuals who are members of chronically disadvantaged communities, people who are in a lower SES bracket, their ethnic minority backgrounds, they identify as being part of the LGBTQ plus community, are also at higher risk for mental health issues following a loss. Part of that is because they have already faced a lot of adversity in life, and they might be coming in with anxiety possibly, or depression. As far as the LGBTQ plus community goes, it is thought that perhaps losing a child is particularly difficult because in order for two men or two women to have a baby together, it has to be very planned and intentional. And sometimes that is a very long and expensive process. I work with a lot of patients who are trying to select a sperm donor or an egg donor or a surrogate, and it's quite emotional. And if somebody, it takes somebody a year to get pregnant after choosing their sperm donor, and then they lose the baby, they can't just try again typically, right? They have to set it up, make sure the donor's on board again, make sure they have resources financially to, if they're going to do this at a clinic, to reproduce. So there's a lot of kind of different factors there for certain populations. We know that not having a child also can increase your risk following a loss, limited social support, instability in your marriage or relationship, that is also very concerning, and lack of knowledge about the medical causes underlying like an adverse reproductive event. Because like I said, unfortunately, a lot of moms, their go-to is to then self-blame.
Right. Wow, there's so much there. And I was thinking that, you talked about unresolved loss, you talked about limited social support, a lack of understanding of the reasoning, and thinking that certainly with some of these, there's certainly things we could do as caregivers and as a culture that could actually help to lower or reduce that risk through education or through support at the time of previous losses or difficulties. So I think that's always right. That kind of gives us kind of some to-dos, some things that we could do that could be helpful. Did you find any protective factors?
Yeah, so for some people, spirituality is a protective factor. It also helps the grieving process for them. Not for others, it just kind of depends where they're at, what their relationship is with spirituality. Social support, of course, is important for basically anything. If you're in a stable relationship, and if you have the ability to invest in goals outside of parenting. So if you're able to re-engage in other things in life that you value, rather than, which just happens to a lot of people, and I can understand why, rather than being hyper focused on parenting and really giving up other aspects of life in order to achieve parenting. That tends to be harder for most people. Something else that we have found that's a protective factor is being able to make a follow-up appointment with your medical provider. Patients find that to be really comforting. I don't really know much about it as far as the psychology underneath it, so I don't want to assume, but studies that have been done that have asked patients what they need following loss, consistently we have seen that patients want to see their provider again, even if there's no new news, just to touch base.
Okay, and that's interesting, and that's coming from the individuals themselves are expressing that desire. So thank you. And I'm wondering, as we're talking about this too, is there any way that that screening can help in this anyway, either to identify whether it's shortly after the loss, or maybe it's been years. You noted a higher risk of couples breaking up up to 9 years later for a stillbirth. So I'm kind of wondering what kind of role you think screening might play in this.
Yeah, that's a great question. Screening seems like this easy thing for all of us to do. However, I am realistic about the limited amount of time that medical providers have, and sometimes they're unable to do that. But I fully believe in and screen whenever I can. And I know that the American College of Gynecologists and Obstetrics as well as the American Academy of Pediatrics also have their own guidelines as far as how often their providers should be screening perinatally. And I think screening is great if you have time for it, because not only does it help you identify patients who might need a higher level of care, it also helps you measure the patient's response to treatments. So let's say I see somebody who has really elevated depression following a loss, and then they see my colleague who's a reproductive psychiatrist, they get started on sertraline. 4 weeks later, we can give them the same test and see if there's been any changes. So because it has a lot of utility. What's a bit tricky is that unlike the postpartum period, there are no psychological assessments specifically to assess mood, anxiety, or PTSD after a loss. So we're kind of using just basic validated measures such as the Patient Health Questionnaire 9, the GAD-7 questionnaire, and then the Post-Traumatic Stress Disorders Checklist for PTSD, because PTSD is unfortunately also common following a loss. Now, all of these instruments are found online, and many of them come in various languages. So we can, make sure that all patients are captured. Something to think about, though, is that the PHQ-9, as well as there's one called the Edinburgh Postnatal Depression Scale, the EPDS, those do ask about suicidal ideation. So as a provider, as a clinic, it's important if you're going to screen to have some sort of backup support or a plan in place as to how to manage, acute suicidal ideation after screening.
Okay, well, that's really helpful. So you're pointing out tools that are available, as well as pointing out a practice gap that we have. So it sounds like one that we should fulfill. So we're talking about screening, which is kind of rolling right into, I think probably, and you've already touched a little bit on like interventions, but I'm just wondering, what types of interventions did you find in the literature that was helpful, both therapeutically, as well as anything with using any medication?
Sure. We don't have any manualized modalities of psychotherapy specifically for reproductive loss yet. However, there's a lot of researchers around the country who are working to develop that. But what psychologists have done is they have adapted existing modalities of psychotherapy, such as cognitive behavioral therapy and interpersonal therapy, to patients who have a history of loss to kind of meet their needs and address their concerns. And there have been a few studies looking at treatment outcome. And what we know is brief internet-based cognitive behavioral therapy was helpful in reducing depression, anxiety, and post-traumatic stress disorder, and grief in parents who have experienced miscarriage. So that's very encouraging. We also know that interpersonal psychotherapy is helpful in reducing symptoms among individuals who experience stillbirth or neonatal demise. So far as cognitive behavioral therapy and interpersonal therapy are the gold standards because we do have treatment outcome for them. But that doesn't mean that other treatments aren't helpful. We just don't know yet. And while the goal is to, send patients to a provider who can do these evidence-based treatments, that might not always be possible, right? Your patient might not be able to afford to go to a provider who can do that. Or maybe you're in a rural area and there are no providers who do, more advanced evidence-based treatment. And so at that point, typically any therapy is better than no therapy. Supportive therapy can be quite powerful and helpful for a lot of people. And so it's when we're referring, it's important for us to be flexible, give them the best option possible, but know that sometimes supportive therapy is the best option that's out there for them. And couples therapy is also important following the loss because of all the reasons that we discussed earlier. That's a referral that I often offer to my patients if I can't see them personally, but it is usually helpful in processing grief and kind of coming back together, hopefully.
Okay. And did you mention in the beginning that there was some research that internet-based CBT was helpful?
Yes.
Okay. Do you want to describe, I don't know, can you describe that a little bit more for us?
Sure. Yeah. It was brief, regimented CBT that again was made sure to be altered so that it talked about loss and was relevant to the patients, but it was just the provider online. I believe it was a group, so there were several participants there at the same time. It was the same principles of cognitive behavioral therapy that one would use for other conditions like chronic pain. And the pre and post measures showed a big change in symptoms, so very encouraging there. And again, it's brief, it's regimented, easy to deliver typically.
Right. Okay. Well, that's all that's encouraging. And I think, of course, right, it like kind of perked because you talked about people in rural communities who may have less access, but also, if there's concerns about being somewhere in person, it's nice to know that there's a little bit more flexibility and that it was actually showing some positive results and support that was there.
Yeah, I think that's so important right now, given that so much of therapy is virtual. It's important, I think, for the provider and the patients to know that it can still work via the screen.
Yes, and I think too, you're pointing out again, there's still some research gaps that are here, but encouraging to know that it's adaptable right now and that it seems to be beneficial. And I think in time, as more attention is placed on this, right, we'll continue to have even better data and guidance. I noted in your article that a number of times you used the phrase compassionate obstetric care. And I would love to hear why did you use that phrase and what does that phrase mean to you?
Yeah, I want to mention that I was really fortunate to work with an interdisciplinary team when I was writing this article. So I worked with a reproductive psychiatrist and a perinatologist, and compassionate obstetrics care is something that I learned from the perinatologist that I was working with. And it's based on this idea that the services and support that we as providers or hospital or the clinic offer to patients following a loss can significantly impact their emotional recovery. And so these are brief targeted interventions that anyone can utilize, even if you have no training in mental health. And compassionate obstetrics care is based on data from patients who have been asked, what do you wish your provider would have said or done? What did you need more of or less of? So it's data driven. So most patients said that they want to be asked how they are doing instead of, again, assumptions around that. Because if a doctor goes in and is very sad and concerned, but that person is relieved about losing a pregnancy, that they might feel some shame about being relieved. So no assumptions are made. They also patients just want normalizing and empathic responses. Who doesn't, right? That's a very valid need that we all have. They want acknowledgement that losing a pregnancy, a child, is not just physically difficult, but there's definitely an emotional aspect to it as well. They don't have to go into it, just acknowledge that it's there. Patients but they appreciate receiving written information about grief and resources that would be helpful for them. Patients want their partners included if they are partnered in that meeting that they have with their provider following the loss. Something else that was important was using providers who use the patient's terminology. So if somebody lost a pregnancy at 8 weeks, but perceives that loss to be a loss of a baby, I would use the word baby. If somebody, lost the pregnancy late into second trimester, but calls a fetus or an embryo, that's what I would call it as well, because their perception is what's most important here. And we just want to support their healing. That's not a good time to necessarily be like, well, after 22 weeks, it's consider something different. That's just usually not good for the healing process. And then, like I said before, referrals to mental health resources. Most patients want that. Now, some patients may be offended by that, but what we have found through research is that most patients do want somewhere to go. Even if they just have grief, it doesn't mean that they shouldn't get professional support.
Okay, well, that's what you just described is really beautiful. What a beautiful description of compassionate obstetric care. I noticed you talked about your approach in even putting this article together was interdisciplinary. I had noted earlier that you had also talked about how it was helpful when there was communication between providers which I heard you say again, kind of come up as a theme. And again, the patient feedback, right? That we're not just guessing or thinking this is what somebody would want or need, but it's the individuals themselves who are expressing that this is what I would like and this is what would be helpful for me. Just thinking how respectful that is, and us taking that time to listen, and then to be able to adequately meet their needs. We're kind of, as people, I'm just going to kind of remind you all, I see some questions coming in. Please have those questions come in because we're going to shortly actually be turning to that. But for a moment, I want to pause from looking at what the paper and the research and the article, because as much as within our professional capacity, we may be thinking of how this is helpful, I would imagine that we probably have in mind a person who we have a more personal relationship with, a friend or a family member that may be still struggling, or we're not even sure because we haven't talked about it. And so on that personal note, what are the things that we can do as an individual to support someone who's experienced a perinatal loss?
Yeah, I really appreciate that question because like we discussed earlier, I think all of us or most of us will be impacted in some way by this. So it's something good to think about, and kind of know what you would want to need, or what your friends might need or family members might need. I think responding to perinatal loss as a loved one, you kind of have to balance following the griever's lead as far as what they need, but also taking some initiative to check in. So some of that depends on the dynamic of the relationship, the personality of the person who experienced the loss. But again, this is not based on data, but just personal clinical experiences. What I have found is that if you contact somebody and they say, I'm not willing to talk right now, or they don't respond at all, sometimes, it might be helpful to be like, well, I'm thinking about you. And if it's okay with you, I'll check in with you in about a week. So just kind of setting up some other times where you'll have contact with them if they are okay with it, because they're much more likely to discuss what they're going through and seek support if they feel like they have some more control over it, rather than a ton of people just emailing them or text messaging them all at once. Some people just don't want to have face-to-face contact right away. Cards in the mail are really supportive and great. For other people, instrumental support is really what they need. So, taking meals over to their house, just asking them, like, do you have the recovery supplies that you need? Do you need a ride to the airport? Not to the airport, to your next doctor's visit. And I think what's most important is to give people space to grieve, and realize that people aren't just grieving the loss of their child. They're also often grieving the loss of confidence that they had in medical science, their bodies, sometimes their partners or loved ones if they didn't react the way that they wanted them to react post-loss. So it's complicated, and there's a lot of layers of grief there, typically, not just, I lost this baby, which in and of itself is very difficult. I wish I had one clear answer for this, but it's so hard to know. And it's so dependent on our dynamic with that person.
Right. No, well, absolutely. And I think that that's so important, because I think sometimes when we see someone in pain, we really wish we had like the 10 magic words, right, to say or to do, but we know that that's going to be so dependent on the person, on their personality, on where they're at, and just their experience themselves. And so, but the guidelines that you've given us are really helpful. And I'm thinking, so a lot of that is like kind of more around the time of the loss. And I'm wondering, like if, I can think of people who their loss was 10 or 20 years ago, and I'm realizing like, oh, I don't know if I even gave them a lot of support at the time. And I'm just wondering if they're okay right now. Like, could you give us just kind of any thoughts on that?
Yeah, and thank you for bringing that up, because the grief can last quite a bit, and the need for support doesn't just vanish a few weeks after the loss. So I think it's, again, back to this idea of like checking in and making your availability known. I've been thinking, and sometimes there's things that could trigger your memory, like with Mother's Day coming up, I've been thinking about you. Um, I know it's been a couple years, but I just want you to know that I'm always here to talk about your loss whenever it works for you. And that I know that grief doesn't just get better all of a sudden.
Right. Okay. Thank you. That's really helpful. Before we go to questions, I would love to know, like, what are your recommendations for future study? I know that people who are tuning in right now to the webinar and those who are going to watch it in the future, sometimes themselves are involved in research, and I think it's really, I think you could actually have some ideas here that maybe others will take you up on. And it seems like there's a lot of work to do, but what are your specific recommendations?
I think that's what's great about doing a review article. It becomes so clear what's missing and not missing. Some of it I mentioned before, like research on the LGBTQ community and how loss impacts each partner. I don't think we have any data on polyamorous relationships and how a loss would impact that. I work in Portland, Oregon, and I have the privilege of seeing patients of all different family structures. And we do work with polyamorous couples who do have a loss sometimes. And I often wonder about how the non-carrying parent, the non-genetic parent is dealing with this, what they might need as they're grieving and healing. We also need research on how surrogates feel when they lose that pregnancy. Now in the US, when you do surrogacy, it's not your egg, it's somebody else's egg and sperm, and you're carrying the embryo, but we really don't know what happens if there's a miscarriage and how those surrogates might react and what they might need, because they have this amazing responsibility of carrying this baby to term, and what happens when that's not the case. So those are just some of the gaps that I thought about, but there's many, many more that I'm overlooking.
Yeah. And you mentioned early on too, just men, you said there wasn't enough research there either, and on their reaction. So,
yes.
Okay, well, thank you. Thank you for that. And let's be ready to go to some of the questions from our participants. So Maddie is asking, can grief be a cause for depression or anxiety?
Yeah, so there's something called disenfranchised grief that can lead to more serious issues. And disenfranchised grief is basically this idea that the person felt like they had nowhere to put the grief or talk about the grief with. And so then they often get stuck in some of the sadness or anger that is a normal part of grief and usually resolves. So it absolutely can. And I'm glad you asked that question, because it's important for us to not just assess once, but to do some ongoing assessment of patients, because studies have shown that right after a loss, a patient may not meet criteria for depression, but then 3 months later, when they were assessed, that they did at that point. So things can change a lot. And part of that change may be that they are stuck in this disenfranchised grief.
Right. Okay. Great. Thank you. And then I'm thinking again, I'm like, oh, that means, in time, if we can do some of the things that you had recommended, it would help to enfranchise the grief and maybe, right, kind of lower that incidence of creating in time depression or anxiety. Well, let's see. I'm looking at Abigail. She's asking specifically with regard to medical or surgical abortions. You have any recommendations about neutral language to use that both provides support to those who experience grief while also avoiding invoking shame in those who do not?
Yeah, that's a great question, because loss can look very different. And even if it's a planned loss, there can still be a lot of difficult feelings around that. There's some great resources in Oregon for that. And I often do send patients to community support groups where they can be around other people who have had similar experiences. I sometimes work with patients who have, had an abortion and then either regret it or feel bad that they don't regret it. So a lot of it is supportive psychotherapy and just giving the patient space to talk about things very candidly with you, because they might not be able to do that with other people, given that there's already stigma about this.
Right, right. And I'm thinking, I mean, this is my own thought. You're free to agree or disagree with it. I think too, whether it's loss through abortion or other reproductive losses, that sometimes we can feel both relief and regret.
Mhm.
And I think that's confusing. And especially I think in a culture that tends not to allow us to have kind of layered or mixed or even what could seem to be contradictory emotions.
Yeah, that's a great point. Because I am often telling patients, like, you can hold both of these things, or you can hold all three of these things at once.
Mhm.
And I agree. I think our culture is like, pick one and stick to it, which is so unrealistic.
Yes. Okay. Well, this will be something for afterward that we could maybe post for the group. Pam is interested if you had a link for the internet CBT, the cognitive behavioral therapy. She's saying they're starting a support group for couples that have experienced miscarriage. And so that might be something that could be helpful.
Yeah, that's
That.
fantastic.
So that's something that we can provide to, if you provide that to us, Jenny, we'll send that
Yeah,
out to participants
yeah. And it's in the
afterward.
article as well, in the
Great.
references. Yeah.
Good. Okay. And everybody has access to that article. Hopefully you've read it, but if you haven't, I hope now you want to go back and comb through it a little bit more carefully. And so you said that's actually in the reference section.
Yes. Yeah. Yeah.
Okay.
And the article also includes the piece that our reproductive psychiatrist wrote about medication management following loss, as well as our perinatologist talking about how to talk to patients about when they should try again or when they want to try again. So there's
Mhm.
a lot more good stuff there outside of me in that article. That's pretty interesting.
Great. Okay. Thank you. So we will provide that. And then um, let's see, I'm seeing here a question. It's saying, asking about like if the emotional features of perinatal loss that you described, is there any difference between someone who has had one loss as opposed to someone who has had multiple losses?
Yeah, there is. We know that individuals who have recurrent pregnancy loss are actually more vulnerable to psychopathology,
Mm.
not only after their losses, but during the subsequent pregnancy as well. And it's thought that these repeated unintentional losses, they come with an accumulation of very difficult feelings and grief, and sometimes people don't even have time to process their grief. Um, and so there was a study that looked at mothers who had had one pregnancy loss and compared it to mothers who had had several pregnancy losses. And what we saw is that mothers who had one pregnancy loss, they had some anxiety during their subsequent pregnancy, understandably so, during the first trimester, but that their anxiety kind of leveled out after that. With individuals who have a history of recurrent pregnancy loss, however, their anxiety stayed elevated throughout their next subsequent pregnancy. So they don't really get a break from it. That could be because, they are more aware of what could go wrong. Maybe they've lost some confidence in their bodies. But it is definitely a different emotional path for some people. And people who do have recurrent pregnancy loss, I think, would particularly benefit from mental health resources if they're open and willing.
Right, right. And I'm thinking, I don't know if this fits in with it, but you had talked about it being helpful when there can be focus kind of outside of the losses or outside of this of this quest to become a parent. And I would imagine that intensifies with someone who has had multiple losses. It may be more difficult for that to happen. So,
Absolutely, because at that point, you likely meet diagnostic criteria for infertility, like the medical condition of infertility. And
right,
my experience of working in the infertility clinic is that those patients are so focused and it's like on to the next step. They're amazing. But yeah, there isn't a lot of time or space to manage
right,
emotions or,
right.
engage in other values that one enjoys.
Great. So, and actually this just builds onto it. Sarah is actually asking just about that, right? For people who every cycle, so perhaps there isn't an early loss of a miscarriage, but they have failed to conceive. And so every cycle they're going through this. So what have you found in your literature or in your practice?
Yeah, that's a great point because it does happen often. And I think if they're doing IVF, there's just so many opportunities for grief along the way. For some people, they have grief about how many numbers of eggs were retrieved. Maybe they were expecting something different. Then they may have grief about how many embryos they were able to create. And then there could be grief about, the embryo transfers not being successful. So, a lot of supportive therapy there as well. But what we do know clinically is after undergoing an embryo transfer, or if they're doing like an intrauterine insemination, the highest anxiety and depression tend to be during the 2-week wait between the procedure and when they can take their pregnancy test. So that's a time where if the patient wants to or is willing, I try to see them more often just to help them get through that 2-week period, just so they have a space to talk about what they're feeling.
Okay. Oh my goodness. And I don't know about you, Dr. Davoudian, but we often hear from couples who are experiencing infertility that they just feel like there's a lack of support and understanding and resources for them. So I think probably another gap that we have. But I know all those who have come today are committed to filling that gap, which is wonderful.
Yeah.
Here's another question. It's a great question. It says, how do you help someone who's resistant towards healing for their loss or becomes agitated when you ask them about it?
Mm-hmm. And is this like professionally help them or personally help them?
It doesn't
both?
say, but perhaps you could address both, because I think that would be relevant for all of us to think both within a caregiving and then also just like a family member or friend that we know.
Yeah, that is a great question. I think professionally it's difficult because we want to honor the patient's requests. We want to respect their boundaries. What might be helpful is checking back in, again, giving it time, checking back in. If they're open to it, also having a discussion about what their concerns are or what they anticipate might happen or come up during therapy for them, and see if that's founded or not. Personally, again, that goes back to like, our relationship with that person. It's going to be harder to approach, I think, in that situation. Again, it's important to check in, ask them what they need. But I think what I've seen from patients, what I've heard from patients is encroachment on boundaries during that time is often not appreciated.
Okay.
So, yeah. I think so, but both ways, you kind of have to play it by ear.
Yeah, and it's so hard, right? When we see someone who's suffering, we want to help, and sometimes they're not ready, which needs to be respected, or maybe we're perceiving something that isn't even an issue for them.
Right.
This is another kind of follow-up question on this. Catherine is saying, we offer reproductive counseling at our center, but I've never had anyone interested in following up later. Do you have any suggestions or verbiage that would help us to help them?
That is interesting. It varies so greatly clinic to clinic. I know so I'm in the clinic, I'm embedded, and the way it works is the fertility doctors or OBGYNs directly just put a referral into the system, and then that person gets called automatically. So I imagine I see a lot of patients who didn't want to come back in, but then they do, and it works. So there's kind of this automatic system that tends to work for patients who are ambivalent. Most patients appreciate the service, and they just need to know that it's there and what it entails, I think, and what insurance you take, and all the
Right.
nitty gritty. But they also might feel, if you're embedded in the clinic and it's an in-person session, they might not want to go back to the clinic because there's trauma there, because they've had 10 embryo transfers that didn't go well. They see that doctor that gave them bad news. So that's also something to consider as well.
Right. No, that's interesting. And I think sometimes, as you've already touched on, just the fact that would be offered can be in itself something that gives permission and support, whether or not the person feels like they need to take advantage of it.
Yeah.
So kind of that enfranchising that we talked about. And then Catherine was saying with a follow-up question, if we do get them back into the center after their miscarriage, should we screen with EPDS?
I do, because they were pregnant, and you know, whether it was earlier or later, they did have a baby. And so typically the postpartum community does say that we can use it. Some providers feel uncomfortable doing it. PHQ-9 is also validated in the perinatal community, so you can always use PHQ-9 if you don't want to use EPDS.
Great. Are these screenings I know I've read the article several times, but I'm just not remembering right now. Are these included in the article?
I don't think so.
Okay, well, maybe
Yeah.
we can provide that as a little follow-up for people as well, because I'm seeing some questions
Sure.
that are here. So I love that people are going to practical application right now. I think we have maybe time for one or two more. There's one of our participants is asking a question of if this information is strictly limited to miscarriage, stillbirth, or loss shortly after birth. Unfortunately, they lost their son at 4 months. And she said that after they left the hospital, there was no recommendations on who they could talk to about their grief or how to process it. Lindsay's saying this was 23 years ago and they made it through it. But it's like, what can we do, right, when we're talking about the loss of an infant?
I'm so sorry to hear about that. It sounds like it was incredibly difficult, and to not have support around it it sounds very, very hard. Some of the data here does include what's considered neonatal death. So it would be more like a month out. In Oregon, we have a great nonprofit that does see patients and provides specific services who have lost their child before the age of 1. So now I think there's just more knowledge and more support out there. I see those patients as well. And yeah, I'm just so sorry that you guys had nothing to work with. Nobody should have to go through that. But now there's pretty good resources, I would say, at least in Oregon. I can't speak to other states.
And kind of going back to the beginning of what Lindsay was saying, obviously there are differences when there's the loss of an infant at this age, but some of the information that you've been sharing, can this be applied when we're talking about perinatal loss and the grief support that you were describing?
Yeah, and what we have seen is that people who do have stillbirth or have neonatal death, their symptoms may be longer a little bit than what we talked about, maybe more enduring, but they're facing a lot of those adversities, unfortunately, that we've discussed earlier today. Yeah,
Okay.
It's not easier in any way.
No, it's not. There were a few more questions, but unfortunately, we're not going to be able to get to them. I think some of them were asking about some risk factors and tendencies, and I think some of that is actually in the article.
Okay.
So hopefully they can go there. But oh my gosh, Dr. Davoudian, again, thank you for your work. Thank you for your compassionate approach that you have, and thank you for taking time to join us here today.
Yeah, thank you for this platform and everybody who tuned in today. It's great to see how many people care about this and the organizations that are out there to support our parents. So thank you all. Have a good day.
Okay, wonderful. Thank you. And I want to echo Dr. Davoudian and thanking everybody who's participated today. We are grateful for the care and concern that you show to better understand and aid men and women, individuals impacted by reproductive loss. Just a couple announcements before we close out. Please fill out your evaluation to complete the class and get your certificate. Your feedback is really valuable to our team. Nurses and licensed clinicians, those evaluations are mandatory for you to earn your continuing education or contact hour. If you enjoyed this event and like to know more, I invite you to check out our other reproductive grief care courses, as well as our past Research Reveals lectures and self-care classes. They're available at the same website that you signed up for this event, lifeperspectiveslearningsystem.com. Remember to check out the healing websites, miscarriagehurts.com, abortionchangesyou.com, as well as those free e-toolkits and our other great resources and remembrance items, including the new Comfort Care box on lifeperspectives.com. Finally, I just like to invite you to consider paying it forward. Help us to keep programs like this available at a really nominal fee, while also displaying your care and compassion for individuals impacted by pregnancy loss by purchasing one of these beautiful forget-me-not pins for a donation of $25. That helps us, and it's going to help others to be able to take advantage of these types of events and our other classes. And of course, please keep your eye out for the next Research Reveals lecture, which is going to happen in March of 2022. Thank you so much for joining us, and thank you for the wonderful work that you do.